Okay. Good morning, everybody. Must be quite a cold and wintry morning for quite a few of you. So today we will be discussing the subject of exercise and congenital heart disease. And this is something that we don't get to talk about often in our day-to-day practice, but it's definitely an important issue for our patients that needs to be discussed with them when they come on their outpatient visits to see us. So when you talk about physical activity and children with congenital heart disease, children with CHD have decreased levels of physical activity when compared to normal children. And they are at a higher risk of obesity as a result. Now, the reason for the decrease in the physical activity is multifactorial, and we will look at that later on in our talk. But it is well recognized that compared to the normal population, that the patients with CHD do perform less. However, they have an overestimation of their activity level. So they think that they are doing more than they are doing. And also they don't have a very clear idea of what they can and can't do. Okay. In addition to all this, of course, a proportion of them will have either genetic problems or syndromic issues. And they can have delayed motor development, which further gets in the way of their physical activity. So what do you think are the factors which contribute to restricted physical activity in patients with CHD? So I'd like some participation here. So what are the factors that lead to restricted physical activity in patients with CHD? Come on, guys, those of you who are logged in. I'm waiting. Any answers? Why do patients with CHD have restricted physical activity? I prefer if we interact so that, becomes a little bit more interesting and you also get to think about the topic a little bit. No answers at all. Yay! Okay, good. So, fixed cardiac output. So, okay, so first we'll look at the hemodynamic or structural factors that can restrict physical activity. Fixed cardiac output. What are the other reasons, apart from left ventricular outflow tract obstruction, what are the other reasons that can reduce your cardiac output? Correct. So, myocardial dysfunction and cardiac output is, what is the formula for cardiac output? What is the formula for cardiac output? How do you calculate cardiac output? What is cardiac output? Correct. Stroke volume times heart rate. So things like myocardial dysfunction and ventricular outflow tract obstruction will reduce your stroke volume. So any condition that affects the heart rate as well can reduce the cardiac output and hence the ability for physical exertion in patients. So, so you have structural and hemodynamic problems like all these conditions that can reduce the cardiac output of the individual. Okay, apart from that, what are the other problems? Like we discussed earlier, patients with congenital heart disease can have delayed motor development. They can have motor deformities, etc. That can also limit their physical activity. So let's just move on and see if we have missed out anything. So we said inability to reduce cardiac output. So either this is an inability to reduce the heart rate, to increase the heart rate, to inability to raise the cardiac output. So either a sinus SA node dysfunction or a heart block, inability to increase the stroke volume, which can be because of decreased preload, reduced contractility, or increased afterload, which we have gone through. Motor developmental delay, and a lot of the time, patients with CHD can also have chest deformities, and as a consequence, they may have some restrictive lung pathology. So there are multiple structural or hemodynamic factors that can give rise to reduced physical activity. But what, apart from the structural and hemodynamic factors, what are the other factors that can lead to reduced physical activity in children with CHD? What are the other psychosocial factors? Often these are more important because a lot of our children will have minor CHD, which either doesn't need treatment or it can be treated easily, so that they have a good hemodynamic result at the end of it. But still, they may be doing much less than what they can do. And why do you think that is? What are the yes, exactly. So absolutely. So parents, the family physician, etc. They advise the patient to limit the physical activity, and this is where your role is very important, because you need to give advice to the patient, which is being a specialist, which is more appropriate and individualized for the patient, so that they can perform to the maximum limit of their ability. So physical activity may be restricted by the practitioner because he may not be up to date with what is possible today and may not be up to date with the guidelines. Of course, there is a fear of medical liability, and to be on the safer side, he may feel that better to restrict the child rather than allow them to do things. Of course, parents can be very protective of their children with CHD, even if it's a small BSD, and they get further, worried when they read media reports, say footballer collapses on the field and he's thought to have some birth defect of the heart. They don't have the ability to differentiate between various cardiac defects. That is something that only we as specialists are probably in a position to do. Of course, the child themselves imposes activity restriction. They may have, a poor body image. They may not be very muscular. May have a very skinny frame. They may have scars on their body from previous surgery. May not be willing to, take their clothes off and change in the changing room. Also, they may have poor fitness because of, lack of previous physical activity. And we all know that when we first start doing exercise, we are very unfit. We're not able to do much, and it's only with repeated exercise that our fitness improves. So all of these factors might also discourage the child from carrying out adequate physical activity. So this is a paper that was published in 2012, and it looks at the prevalence of obesity in children with CHD and compares it with the general population from a national database. And this study found that when you looked at patients with heart disease overall that are seen by a pediatric cardiology practice, the prevalence of obesity is not more than general population. So I think the overall prevalence of obesity in the national database is about 30%. This is in children with in children, and children with CHD had a very similar prevalence at about 26%. However, when they looked at the various subgroups of patients and they subdivided them into those with heart disease, but insignificant heart disease, where it says HD, no intervention. And those with, say, electrophysiological problems, often minor. And compared them with patients who had undergone, say, biventricular repair like tetralogy and single ventricle palliation like a Fontan, they found that there was a significant difference. Patients who had had single ventricle palliation or biventricular repair generally had a tendency to be less obese. So these patients, as a whole, as a cohort, they have a tendency to fail to thrive, and they're often not very obese. Whereas it's the patients with minor problems, perhaps a small BST or an electrophysiological problem that is of no consequence, these patients tended to be more obese. They were restricted more than they needed to be. So these are often patients that can exercise to the capacity of a healthy child. But these patients were being restricted either by their family or by themselves, and they were not doing enough, and they were, as a consequence, more obese. So if you look at the risk factors for obesity, you can classify them into two. See, obesity happens when the calorie intake is much greater than the calorie expenditure. So obesity can happen when there is a high calorie intake or a low calorie expenditure. So high calorie intake often happens prior to a cardiac intervention, particularly in patients with a large left to right shunt, for example. So we often give advice to parents to increase the weight of the child, to give high calorie foods and perhaps additives, so that the patient will put on weight, become bigger, and the risk of surgery will be reduced. However, what we fail to do is to tell these parents after the intervention has been carried out to then normalize the diet so that the patient can grow, along the normal growth curve. So we, even though we monitor growth very closely prior to the cardiac intervention, we often fail to do that once the cardiac problem has been rectified. So high calorie intake can be a risk factor for obesity. Similarly, restricted physical activity. We have already gone through the various reasons as to why patients with CHD restricts their physical activity. And we know that it is multifactorial. Both these can contribute to obesity. So what is the impact of obesity on the cardiovascular health of these patients? Does it really matter? Childhood obesity, how does it translate into adult cardiovascular health? Now, there is enough data to show that childhood obesity is related to adult obesity. There was a study called the Bogalusa Heart Study. This was an epidemiological study that was carried out in the 70s, and it looked at children and various factors, including weight, and tried to follow them up to see how the various factors translated into adult cardiovascular risk. And they found that childhood obesity was significantly associated with adult obesity. Also, childhood obesity, we know through various studies, associated with hypertension, type 2 diabetes, and metabolic syndrome in children. All of these, childhood adverse cardiovascular factors, including dyslipidemia, translate into adult adverse cardiovascular factors. So all of these increase the risk of the individual for adult, cardiovascular problems. Also, markers of coronary artery disease like carotid intimal thickness, peripheral vascular stiffness, etc., have been assessed in obese children, and they have been found to be abnormal. So childhood obesity is not a benign phenomenon. It is a phenomenon that has to be taken seriously, both in the so-called normal population and in patients with CHD. In fact, patients with CHD are at particular risk because already they have had an underlying heart problem. So one can argue that the myocardium has already undergone some insult during childhood, say at the time of cardiopulmonary bypass. And then it is important to preserve that myocardium for the longer term. There are certain conditions in congenital heart disease that have a specific high risk for coronary artery disease. And these, as you are quite aware, are those operations that involve coronary artery translocation, and this includes the arterial switch, the Ross operation, surgery for Al-Kappa, and also diseases that affect the coronary artery like Kawasaki disease. So these patients are at particularly high risk for ischemic heart disease or coronary artery problems later on in life, and this is something that needs to be monitored regularly. In this study that was published quite early on in 2000, patients who were in an adult congenital heart disease clinic were given a questionnaire to determine their activity levels, also to find out what kind of advice they had received regarding exercise, how much they knew about their heart condition, and about how much activity they were allowed. Nearly 70% of individuals had never had a discussion about exercise in their outpatient clinics. I think if we looked at our own practice today, many of us perhaps don't have the time or the inclination to sit down and give patients this advice. I think we are often more excited about the rims of an ASD or the closure of a pinhole VSD that really doesn't need closing, but not many of us actually pay attention to the topic of these various important lifestyle issues like exercise, contraception, pregnancy, all these things that are actually much more important to a patient than the things that we get excited about. But so worryingly, nearly 70. This was in the developed world, which had been doing quite a lot of congenital heart disease work for many years. 70% of patients did not have this conversation about exercise with their pediatric cardiologists or adult congenital heart disease specialists. When you look at the graph on the right, this compares the recommended activity level with the actual activity level that the patient was doing. So the empty boxes are the activity levels recommended by the American Heart Association, and the colored in boxes or the dark black boxes indicate the actual activity that the patients were doing. According to the AHA recommendation, nearly 70% of patients should have been in activity levels 1 and 2, which is either no restriction or they were minimal restriction where they're allowed moderate exercise, including running, tennis, football, etc. But if you notice, only half this number, only 35% of people were actually performing in these two groups. Okay, and most of them, were actually performing below what they could be doing. So the activity level of the patient was much lower than what they could have possibly done. And this is probably related to the fact that they did not get appropriate counseling and support from the carers. So before giving advice to patients on their exercise regimes, it is often useful to know to assess the exercise capacity of the patient. There are various ways of assessing a patient's exercise capacity, and the method of assessment will have to be decided based on the underlying condition of the patient, the general condition of the patient, etc. So these are the three commonly used methodologies. One is the 6-minute walk test. The other is the treadmill test or exercise test that we use. And finally, you have the cardiopulmonary exercise test. This is actually a topic to be discussed in its own right, but I will aim to give a brief overview of the three testing methods. So the 6-minute walk test is carried out usually in patients who are quite significantly limited, who cannot carry out a treadmill test. This involves walking a patient along a track for 6 minutes to determine how long they can walk. Okay, usually the track will have to be a minimum of at least 30 meters, and this is most useful in limited patients. So if a patient has a good exercise capacity, this test may not have much value. It is better then for them to go for a treadmill test. The usual strategy is that there is a nurse or a paramedical worker who stands with the patient and supervises the 6-minute walk test, as it is often done in an uncontrolled manner without monitoring. It is also useful to determine the saturation prior to the test and after the test, particularly, for example, if we are looking at assessment of operability in left-right shunts, in borderline patients, this can be a useful tool. The other situation it can be helpful is if you're looking at, say, for example, a fenestrated fontan who's doing well, and you want to know whether you can close the fenestration. Sometimes exercising them can be useful to see how cyanotic they get. Once again, in pulmonary hypertensive patients like Eisenmenger patients, the degree of desaturation gives you an indication, as to how bad the pulmonary hypertension is and what their exercise capacity is. Because cyanosis per se will limit the ability of the patient to exercise. So that is a 6-minute walk test. Next, we move on to the treadmill test, or the the traditional exercise test that is carried out in the adult cardiac patients. In children, there are some specific problems with treadmill testing. Although treadmill testing can be carried out in fairly young children, as young as, say, 7 to 8 years, provided they can understand what you're asking them to do and cooperate. Sometimes, in certain conditions, for example, aortic stenosis, you may start exercise testing the patient at an early age, not with the idea of necessarily getting a perfect result, but with the idea of getting them used to the concept of exercise testing. So an exercise test in a child requires a child-friendly environment, a technician who knows how to handle children, and essentially what they need is a lot of encouragement so that they perform to the maximum limit of their ability, rather than giving up because of boredom or fear or anxiety. So the whole trick is to get them to exercise to the limits of their ability. Sometimes we need to use modified protocols if they're not able to handle the high speed of the belt or the incline. But the idea is to try and get them to do as much as they can, so that we can glean as much information as we can from the exercise test. So during the treadmill test, the important things that they're looking at are eliciting symptoms. For example, a patient with chest pain or palpitations on exercise, do they get these symptoms during our exercise test? We're looking for ECG changes, particularly useful in either an ischemic type of situation, or in, for example, aortic stenosis, which is moderate to severe, and we're trying to take a call about whether this patient is ready for surgery. If there are ECG changes of LV strain, T-wave inversion or ST segment changes, then it would push you towards going for intervention. Then blood pressure response. We're looking for an appropriate increase in the blood pressure on exercise. So if you don't have an adequate blood pressure response, or you have a fall in the BP on exercise, this would be an ominous sign. Once again, useful in left ventricular outflow tract obstruction situations, because you have a fixed outflow tract obstruction. On exercise, the systemic vascular resistance will drop. So you can have a blunted response to exercise or a fall in BP. And this would once again push you towards intervention. You can have an inappropriately high blood pressure response, for example, in patients with coarctation of aorta. So they have an intrinsic tendency towards hypertension, and even though their BP might be normal at rest, they can have an abnormal response, blood pressure response on exercise. And if this happens, then they may need some antihypertensive therapy once the coarctation has been repaired. Okay. Saturation response is the other one that we look at, just like the 6-minute walk test. Particularly in patients who have a left to right shunt or right to left shunt, then you have, with the fall in SVR, you expect that there will be more of a right to left shunt. So when you're assessing a right to left shunt, then exercising them could potentially lead to a drop in the SpO2. So finally, we come to the cardiopulmonary exercise test. This is quite an extensive topic, but essentially what it involves is a controlled environment in which exercise is carried out, and the patient is essentially made to breathe in gases whose composition we know. So the patient is given a gas mixture. Okay, the inspired FiO2 and CO2 are known to us. Then they exhale, and that air is collected so that the expired oxygen and carbon dioxide content can be measured. So because we know the expired oxygen and carbon dioxide concentration, and we can measure the expired oxygen and carbon dioxide concentration, we can find out or determine what is the oxygen consumption of the patient during exercise. So that is the basic fundamental. Other parameters are also calculated. So we look at the heart rate of the patient. A good heart rate response is quite important. That is a normal response of the heart to exercise. In an adult patient with acquired heart disease, we have this concept of a target heart rate. So it's usually defined as 220 minus the patient's age. This may not be completely applicable to children, and we don't use it, as rigidly as in adult practice. Often patients with congenital heart disease, particularly adult congenital heart disease post-repair, can have chronotropic incompetence, and they may not be able to mount their heart rate to the levels that are expected with exercise. Overall, in these patients, chronotropic incompetence is a bad prognostic feature. But that is something that can be assessed during cardiopulmonary exercise testing. Now, whether a patient has exercised adequately can be measured by this entity called respiratory exchange ratio. Basically, it looks at the CO2, the ratio of the CO2 and oxygen, and this is the expired CO2. And normally at rest, the value is 0.8. With exercise, we expect it to increase. So if you get a value of 1.1 approximately, it means that the patient has exercised to the limits of their ability. So hence there are, and if they have exercised to the limits of their ability, it means that we can rely on the various parameters that we have, like peak oxygen consumption, etc., that these are all reliable parameters. So respiratory exchange ratio essentially assesses the effort of the patient. Has the patient exercised to the maximum that they are able to do? Okay, so there are several parameters in the cardiopulmonary exercise test that are useful in our assessment of the exercise capacity of the individual. Now, I'm sure you're aware that in terms of the actual kind of exercising that a patient can do, either they can get on a treadmill and run, or there are other ways like a bicycle ergometer. So the patient is not able to run, they can sit on a bike and they can cycle. Okay, so there is published data on the CPEX findings in various congenital heart diseases. So this is a table which looks at quite a variety of CHD, and the pluses indicate how commonly these abnormalities are found. Okay, so this is decreased oxygen consumption, for example. So this is rarely seen in things like isolated PR, okay, and maybe sometimes seen in coarctation. but very commonly seen in patients with Fontan circulation or Eisenmenger pulmonary vascular disease or dilated cardiomyopathy. These subsets of patients very commonly have a reduced oxygen consumption. Similarly, this once again looks at the chronotropic response. So usually most of these conditions there is an adequate response, heart rate response to exercise. This can sometimes be blunted. So chronotropic incompetence is sometimes seen in patients with Fontan circulation, perhaps patients who had a mustard or Senning operation, like post-atrial switch. They may also have chronotropic incompetence. So in this fashion, various exercise parameters, have been listed in this table in the various subgroups of patients with congenital heart disease. So I think we're all convinced that exercise is quite important and that advice regarding exercise should be given to patients with CHD so that they can maintain good cardiovascular health in the long term. So with this in mind, in 2012, there was a task force from Europe that published guidelines for physical activity, recreational sport, and exercise training in pediatric patients with congenital heart disease. It's quite a useful document. It's a fairly big document. And it's something that I think we can perhaps keep in our outpatient clinics to refer to if we need to give specific physical activity advice to our patients. So first of all, they defined various terminologies. So, physical activity is any movement that results from muscle contraction that increases the metabolic rate above the resting level. Okay, so this is what is called MET. Okay, the metabolic equivalent of task. So vigorous activity is any activity that increases your metabolic rate greater than 6 times baseline. Moderate to vigorous is if the patient achieves 3 to 6 METs. Then various definitions of leisure sport. Leisure sport is where you have physical activity, but there is no pressure to compete. So you're not competing either with yourself or with your peers. Competitive sport is when you're competing. You're trying to improve your own performance, or you're trying to compete with, with other peers or with the opposing team. That is competitive sport. And then a sedentary lifestyle, which applies to not only patients with congenital heart disease, but also us, is when you spend too much time, doing sedentary activities and also too little time doing physical activity. So the normal activity recommendation for a normal individual, for you and me, is at least 60 minutes of moderate to vigorous activity, physical activity, and less than 2 hours of sedentary time. I think our sedentary time has significantly gone up with our urban lifestyles when we spend quite a bit of time in front of computers or iPad or iPhone or the television. So I think we, as a population and as a generation, need to be aware of the risks, cardiovascular risks of our lifestyle. So this is a very nice diagram which classifies the various physical activities. Okay, so I think we're all aware that exercise is classified into 2 types. One is cardiovascular exercise, where there is a high dynamic component. The other is a musculoskeletal kind of exercise, bodybuilding type of exercise, where there is an increased static component. Okay, so there are activities like, for example, running, tennis, etc., where there is a very high cardiovascular component, a lot of movement. This is typically what we would call aerobic exercise. So this includes things like badminton, running, tennis, soccer, race walking, blah, blah, blah. Okay, and then we have activities on the exact opposite end of the spectrum, like weightlifting, which have a high static component, not much of a dynamic component. So sailing, climbing, weightlifting. These are all some activities with a high musculoskeletal or static component and a very low dynamic or cardiovascular component. Activities like golf and billiards are very low intensity activities. Okay, they have a low static and dynamic component, whereas things like cycling and rowing, they have a high dynamic and static component. So activities can be broadly classified. So this quite a nice figure or diagram classifies various physical activities depending on whether they are more static or more dynamic. And this can also be useful to you when you're giving specific advice to young patients. So we have already mentioned this, that the recommendations for a normal individual are at least 60 minutes of moderate to vigorous exercise and not more than 2 hours of sedentary activities. So the paper goes on further to help us with executing the recommendations. So the recommendations are that we give physical activity counseling. So targeted counseling, we talk about physical activity. What do you do? What are the activities that you undertake? What are you interested in? And if they're doing too little, to give them advice about what they can do. You can also give a written physical activity prescription, just like you prescribe medications. You prescribe, these are the things that this patient can do, these are the things to be avoided, etc. So that the family practitioner and the parents have a written document which they can refer to in case they have any queries. Of course, there needs to be regular assessment of activity levels. There are certain conditions. One classical example would be aortic stenosis, where there can be progression of disease, okay, and your physical activity advice will change based on the severity of the problem. So a patient with mild aortic stenosis need not have any restriction in physical activity, so they can take part in competitive sport like any healthy individual. But when this mild aortic stenosis becomes moderate to severe, then you will have to restrict the intensity of the activity to low to moderate intensity of competitive sport. So you will have to give slightly different advice. Also, the thing to be borne in mind is in certain conditions where you're expecting the condition to progress, it is important to warn the patient and the family of your expectation. For example, in aortic stenosis, if you have a patient who wants to do competitive sport at a very high level, this may be a problem for them in the future, because if the aortic stenosis progresses, as we know it most usually does, then at some point he may need some form of intervention. He may need to be off training for that. Also, if he ends up with a valve replacement at a fairly young age, then you need to put him on anticoagulation. This could stop him from taking part in certain contact sports. So these are all various factors. So perhaps it is worthwhile to try and counsel the patient so that they can think of an alternative career choice or lifestyle choice. So the paper, the guideline has actually given a very detailed recommendation for each of these heart diseases or groups of heart diseases that we see in our patients in our day-to-day practice. What I will aim to do is perhaps quickly go through some of the important ones, but you can refer to them, in the paper that I've mentioned for your day-to-day practice if you cannot remember. So healthy children, like we said, they can do. They're recommended to do at least 60 minutes of moderate to vigorous physical activity every day. They can participate in competitive sport, leisure sport, and their physical activity is essentially unrestricted. This is healthy children. Musculoskeletal activities can be done 2 to 3 days in a week within safe limits so that they don't get injured. Okay, and they should have less than 2 hours of screen time. This is the normal recommendation. When patients have septal defects, often when these are large, these are nowadays corrected early, and they can be treated like healthy individuals. If there is a small uncorrected VSD or ASD, for example, that can also be treated like a healthy individual. Okay, if patients have had VSD surgery or device placement, then 3 to 6 months after the procedure, their activities are restricted to light activity until the device has endothelialized and settled in, and until the sternotomy has healed. Patients with aortic stenosis need to be assessed. They need to have a treadmill test like we discussed earlier, particularly looking at ECG changes, blood pressure response, and any symptoms. So, as you all know, any syncope that happens in a patient with aortic stenosis is an ominous sign. So, this would be one of the symptoms that we look for, along with chest pain. On the ECG, we are looking for LV strain, so STT changes. And as far as the blood pressure is concerned, we look to see if there is an increase in the blood pressure, there's a blunted increase or a fall in BP. These are signs that the aortic stenosis may be significant. In patients with mild AS, they can be treated like healthy individuals, like I mentioned earlier. Moderate AS patients can have light to moderate intensity comparative sport. Okay. This is as far as the cardiovascular kind of more dynamic sport is concerned. As far as the musculoskeletal sport or the static sport is concerned, once again, they're allowed only light to moderate intensity. And frankly, this is something that I would not particularly encourage. Perhaps if they're very much into bodybuilding, they can do light weights, but I would not encourage them taking on heavy weights and doing heavy bodybuilding at the gym. So it's something that I would give specific advice about. Patients with aortic stenosis need to be assessed at regular intervals. Now, as we are all aware, aortic stenosis can be at multiple levels. It can be subvalvar, for example, hypertrophic cardiomyopathy. It can be valvar, which is the classical aortic stenosis that we see in adulthood, and it can be supravalvar. So patients with hypertrophic cardiomyopathy may have specific issues like cardiac arrhythmia. Also, when there is a dynamic aortic stenosis, exercise can exacerbate that gradient. So that is something to be assessed as well. So often patients with hypertrophic cardiomyopathy, when they don't have a resting gradient, you would exercise them and then repeat their echo to see if they develop a dynamic gradient. If they do have a dynamic gradient that is significant, they may benefit from beta blocker therapy. Patients with supravalvar aortic stenosis can sometimes have involvement of the coronary arteries. And that would be, once again, a risk factor for exercise. So those patients, you would particularly look for signs of ischemia on the exercise test. So each subgroup is slightly unique, but these are general guidelines that you can apply. Aortic regurgitation, generally mild to moderate AR. There are no restrictions and they can be treated like healthy individuals. But if they have severe AR, obviously with left heart dilatation, then you need to intervene and rectify the problem. Bicuspid aortic valve, again, the restriction depends on the associated problems, whether they have aortic stenosis or regurgitation or aortic root dilatation. Just isolated bicuspid aortic valve does not have any restrictions. If they have dilated aorta, if it is only mild dilatation, they can be treated like healthy individuals, but they have more than mild, then you have to limit their activity levels to low to moderate intensity cardiorespiratory activities. But the musculoskeletal or static activity should be highly restricted, because these are patients who are prone to aortic rupture, if the aneurysm progresses. So I would not, once again, this is another group of patients that I would strongly discourage weightlifting and intensive musculoskeletal activity. Coarctation of aorta, often if it is significant, it is treated. And once they have been treated, they can be treated like healthy individuals. There is some restriction on the musculoskeletal activities to light to moderate intensity. And these patients would benefit from exercise testing to rule out an abnormal blood pressure response. And if they have an abnormal blood pressure response on exertion, which is defined as 3 times the normal response, then they would benefit from medical therapy. Then we move on to pulmonary stenosis. Mild pulmonary stenosis can be treated like healthy. Moderate, you limit to low to moderate intensity competitive sport. Tetralogy of Fallot, once it has been repaired, can be treated like healthy. These patients often need an exercise test and Holter because you know that they are a subgroup that are prone to arrhythmias. So exercise-induced ventricular tachycardia, for example, is an important thing to look for, or any ventricular arrhythmia on Holter monitoring. They can also have SVTs, as you're aware. Now, you know that patients with tetralogy, the arrhythmia problem is usually related to a hemodynamic problem. So usually things like ventricular tachycardia coexist with significant pulmonary regurgitation and RV dilatation. So it is an indication often for pulmonary valve replacement. Then just isolated pulmonary or tricuspid valve regurgitation, they can still undertake as long as the RV is reasonable, they can still undertake at least moderate intensity competitive sport. So if you look at several of the conditions, there are not many restrictions. Transposition of great arteries, which has been repaired, you do limit them to moderate intensity competitive sport, both dynamic and static, and they are recommended to have exercise testing and Holter monitoring at regular intervals. And this is primarily with detecting coronary artery abnormalities in mind. Then congenitally corrected transposition, obviously you're worried about the systemic right ventricle, once again limited to low to moderate intensity competitive sport. But you have to note that it says competitive sport. So this actually, when you say low to moderate intensity competitive sport, it means that they can actually carry out pretty much most of the activities that any normal person would carry out as exercise. They can run on a treadmill, they can swim, they can play tennis. So when you say competitive sport, you're talking at a high level, competing. So I think even though it says low to moderate intensity competitive sport, in day-to-day practical terms for a normal individual, this is pretty much not much restriction at all. I think mainly the advice for congenital heart disease patients would be in relation to the weightlifting and static exercise, which you would limit in many conditions. And if they are very keen on weights, what you can advise them is they do low weights and repetitions rather than lifting very high, crazy amounts of weights. The Fontan, once again, is limited to only low intensity weightlifting or static exercise and low to moderate intensity cardiovascular exercise. But a good Fontan patient can undertake most activities. He can, do cycling on the flat without any problems, maybe even mild uphill cycling, running, swimming, etc. Patients with pulmonary hypertension or Eisenmenger, you have to individualize the recommendations and based on the clinical status of the patient. Often these patients are quite limited, and although you wouldn't push them, you would encourage some form of regular exercise. There is some evidence to show that physical training or rehabilitation does improve the exercise capacity of these patients. So there are several studies that look at cardiac rehabilitation in congenital heart disease, and they're all studies with small numbers of patients, as you can see here, variable kind of pathologies and modalities. And they have variable results. And some of them have shown that there's been an increase in the peak VO2 max in some of these patients, but I think the results are slightly inconclusive. Recently, there have been a few more papers published, particularly looking to differentiate between single ventricle type of patients and biventricular repair patients. And generally what they have found is that patients with a single ventricle circulation do not seem to benefit much from habitual exercise, in terms of their improvement in exercise capacity when compared to biventricular patients. So biventricular patients seem to actually increase their VO2 max with exercise, but not the patients in the Fontan group. I don't think this literature should stop us from advising exercise to our patients. I think in the Fontan group, perhaps regular exercise does not have the same level of benefit that you see in patients, say, with repaired tetralogy. But I think overall exercise improves the sense of well-being and I'm sure has some beneficial effects. It's not shown to be detrimental anyway. So I would still encourage some form of regular exercise in patients with Fontan circulation. Once again, this is the pulmonary hypertension data that I mentioned to you. It has been shown that cardiac rehabilitation does improve the exercise capacity and chronotropic response and oxygen consumption in these patients. But look at the small number of patients. So these are also low-risk Eisenmenger type patients where the PA pressure is less than 3/4 systemic. Okay. So now that we have more or less covered structural heart disease, this is another paper that lays down recommendations for activity in patients with cardiac arrhythmia. This was not specifically published for congenital heart disease patients, but for all patients with cardiac arrhythmia. Now we know that we often come across patients with ventricular ectopics in our day-to-day practice, and ventricular ectopics are most often benign phenomena. However, it is important to evaluate them properly so that we rule out any significant condition that needs specific treatment or has a poor prognosis. So ventricular ectopics, when they are asymptomatic, when there is no family history of sudden death, when there are less than 2,000 ventricular ectopics on a 24-hour monitor, when there are no couplets and they are monomorphic ventricular ectopics, are usually benign. So essentially, when we assess ventricular ectopics, we carry out a basic kind of a set of tests. One would be an ECG, the other would probably be a Holter. Then we would do an echo just to rule out structural heart disease. Usually the heart is normal on echo. And then we would do an exercise test. So if the ventricular ectopics disappear on exercise, it is a reassuring sign. Okay. So when you have these benign ectopics, you don't restrict the patient. They can continue with a normal life. Okay, and normal activity levels. You follow them up annually, but you don't restrict them, and you take a fairly reassuring line with them. If, however, they are symptomatic, if there are more than 2,000 per 24 hours, if they are polymorphic or there are couplets, or if they increase with exercise, then you go through a process called deconditioning, which is for 3 months you take them off the exercise, and then you repeat the assessment again. If after coming off exercise, the assessment is normal, then once again, if the ectopics resolve, you can allow sports. Okay. However, if there is underlying cardiovascular disease, if there is structural heart disease, or if you have channelopathies, then you will restrict competitive sport and allow only leisure activities, avoiding sudden bursts of activities. Similarly, you have recommendations for non-sustained and sustained ventricular arrhythmias. That is, if they are asymptomatic and the typical right ventricular outflow tract type of VT, that is relatively benign and you can allow sports. Once it has been ablated, if there is no recurrence, then once again they can have unlimited competitive sporting activity. This is if it's an automatic focus, like a RVOT tachycardia. If it is a re-entrant arrhythmia, you don't allow competitive sports. So the cause or the underlying mechanism of the arrhythmia also is important. Of course, if you have, cardiac arrest and a significant reason for the VT, for example, long QT syndrome or arrhythmogenic, right ventricle or a catechol-aminergic VT, these conditions, sport is contraindicated. So I think we've already had a look at this. So to evaluate VT, sometimes MRI is required. So with your initial basic assessment that we discussed already, if there are still concerns, then you would undertake more advanced imaging like an MRI, which can detect problems like arrhythmogenic right ventricular dysplasia, and sometimes these patients require EP study and stim. And this would be particularly in situations like the RVOT tachycardia, where it can then be ablated. There are specific ECG features for various conditions, and what you're looking for are, in VT, if you have a ventricular tachycardia that is monomorphic with an inferior axis and left bundle branch block, then it's more likely to be a RVOT VT, and it's often benign. You look for channelopathies. These have a poor prognosis, like long QT syndrome, like Brugada syndrome, etc. So once again, there's a huge list here with recommendations for long QT, short QT, Brugada, catechol-aminergic VT, etc. So the important point is that for long QT syndrome, no competitive sport is allowed. Only leisure activity is allowed. Whether it is a silent gene carrier or a phenotypically overt individual. Okay. Similarly, for Brugada syndrome, competitive sport with low cardiovascular demand, so maybe golf, at a competitive level. For long QT also, I failed to mention, there are certain trigger factors like diving and swimming in certain types of long QT can bring on the tachyarrhythmia, so that should be avoided. Once again, catechol-aminergic VT is a very exercise-specific arrhythmia, and competitive sport should be avoided at all costs. So what about patients with implantable defibrillators? Essentially, they are not allowed any competitive sports, except if it's a very low cardiovascular demand. So perhaps if it's like billiards or golf or something like that, they can play it at competitive level. Things like golf, however, they have to be careful because there are leads that could get crushed or displaced. So any activity that involves a lot of arm swinging should also be curtailed. Leisure sport is allowed about 6 weeks after the implant. So once you're happy that the leads have settled in, then leisure sport is allowed. Okay. Once they have had an ICD shock or pacing, they should refrain from physical activity for about 6 weeks. So there are certain restrictions for these patients with cardiac rhythm problems, but I wouldn't keep them off all activity. Once again, just like the previous recommendations, you have to bear in mind that these recommendations are primarily giving you some guidelines for competitive activity. So a lot of patients can actually perform leisure time activity up to a moderate intensity. Specific conditions, rhythm conditions in which you have to be very careful about activity are the channelopathies. Catechol-aminergic VT is particularly, exercise-sensitive VT. Here, in these conditions, you don't allow competitive sport, and you allow only leisure time sport either to a low or moderate intensity. Okay, so I think that kind of brings me to the end of this overview about exercise. I'm sorry it has been very didactic and I've had to lecture to you, but the nature of the topic is such that there are a lot of guidelines and there's a lot of data. I would strongly recommend that you get these guidelines downloaded and you have it with you in your outpatient practice so that you can use it as a reference to advise your patients regarding physical activity. If there are any questions from you right now, I'll take them. Otherwise, I think we have come to the end of our talk. Anything from any of you guys? No? Okay, if everyone is happy, then I think we'll probably sign off now. Okay, have a good day. Bye-bye.